heart failure. We will cover definition and general classification, etiology, clinical features, diagnosis, differential diagnosis, and treatment. So, acute heart failure means the rapid onset or worsening of heart failure symptoms, and it's a common cause of hospitalization in older patients. It can be either new, which is called de novo heart failure, or it can be acute decompensation of already having heart failure. So acute decompensated heart failure, as I said, is acute heart failure due to a decompensation of a pre-existing disease or cardiomyopathy. It's the most common form of acute heart failure. And de novo heart failure, it's an acute heart failure occurring for the first time in a patient without a known cardiomyopathy. It takes about 15% of cases. Etiology, de novo heart failure, it can be caused by an acute myocardial dysfunction, which can be like cardiac ischemia after an acute coronary syndrome. It can be due to myocarditis, drug-induced cardiomyopathy, peripartum cardiomyopathy, thyroid storm, tachycardia-induced cardiomyopathy, Takotsubo cardiomyopathy. This can be also caused due to an acquired valvulopathy, like an acute mitral regurgitation following acute coronary syndrome, or due to bacterial endocarditis, or even non-bacterial thrombotic endocarditis. This can be also due to extracardiac pathologies which affect left ventricular output, like pulmonary embolism or pericardial effusion causing tamponade. Or aortic dissection can be also a cause. Acute decompensated heart failure can be caused by an uncontrolled or refractory hypertension, or both of them, new or worsening of a cardiac ischemia. It can be due to arrhythmias like atrial fibrillation with a rapid ventricular response, complete heart block. It can be due to some serious infection like sepsis, pneumonia, drugs, for example, patient non-adhering to heart failure medications, or NSAIDs use, negative inotropes like non-dehydropyridine calcium channel blockers, statin or abscissurating beta blockers, thiazolidinedione like diabetes malicious medications, substance use like cocaine, alcohol, methamphetamines. It can be due to other conditions like anemia, renal failure, or volume overload due to a patient non-complying to a diet and consuming a high salt diet or IV fluid therapy. And also in 40-50% of cases, no trigger is found. Speaking about the clinical features of an acute heart failure, either the patient will be presenting with an evidence of congestion, or the patient will be presenting with no evidence of congestion. So if the patient has an evidence of congestion, either it's going to be an adequate perfusion to the tissues or hypoperfusion. So with adequate perfusion, the patient will be having warm and wet skin. In hypoperfusion, it will be cold and wet. When there is no evidence of congestion, with adequate perfusion, it will be dry skin and warm, and with hypoperfusion, it will be cold and dry. The patient will be presenting either symptoms of left-sided heart failure or right-sided heart failure, or sometimes both. So for the symptoms of left-sided heart failure, it will be acute dyspnea, orthopnea, which is worsening of dyspnea on lying down, symptoms of increased work of breathing, cough, which can be also occasionally with frothy blood-tinged sputum. On auscultation, we may have rales, crackles, wheezing occasionally as well can be found. Central cyanosis can be present in severe cases. Symptoms of right-sided heart failure can be presented by jugular venous distension, presence of hepatojugular reflux on clinical examination, peripheral edema, ascites, and hepatomegaly. Flash pulmonary edema can be present as well, which means actually a presence of pulmonary edema which happens really quickly, and it manifests usually with hypertension, pulmonary congestion, and minimal peripheral edema. In hypoperfusion, we will see that the patient is presenting with weakness, fatigue, altered mental status, signs of poor peripheral perfusion like clammy skin, peripheral cyanosis, skin mottling. For the blood pressure, it can be low, it can be normal, or it can be elevated depending on the patient, and it should be also interpreted in relation to the baseline blood pressure of the patient. The combined presence of jugular venous distension, the presence of S3, gallop, and long coracoles or rales makes a diagnosis of acute heart failure highly likely. And we should also assess for clinical features which are suggestive of hypoperfusion, like presence of narrow pulse pressure, cool extremities, peripheral cyanosis, altered mental status, blood pressure which is below the baseline, to identify the patients with or at high risk of presenting with cardiogenic shock. So, in diagnosis, we will do some lab studies. We have the BNP and NT-proBNP. So BNP, when it's more than 500, we can say that heart failure is likely present. NT-proBNP more than 1000, also heart failure is likely present. We have to check troponin levels to rule out myocardial ischemia and acute coronary syndrome. Basal metabolic panel, we check CBC also for seeing if the patient is presenting with any signs of sepsis, infection, or inflammation. Liver chemistries, we consider also a thyroid function test, and also we may consider renal function tests as well. ECG. In ECG, it can be presented signs of ischemia due to an acute coronary syndrome with changes of the SCNT waves. It can be presented with atrial fibrillation, left ventricular hypertrophy, meeting the Sokolov criteria. It can be also bundle branch block or non-specific ST segment changes, low voltage QRS, which can be presented in pericardial effusion or pleural effusion, peripheral edema, or pulmonary edema secondary to acute heart failure. We can do an X-ray as well, especially to check for signs of a pleural effusion and or a pericardial effusion. Also, it may show us remodeling signs like enlarged heart shadow due to cardiomyopathy, or also due to the presence of pericardial effusion. We have to do also transthoracic echocardiography to check for left ventricular ejection fraction. It can be either normal or reduced, to check for diastolic dysfunction, left atrial dilation, valvular pathologies, pericardial effusion, right ventricular systolic dysfunction, increase in the right ventricular systolic pressures. For differential diagnosis of acute heart failure with other pathologies, we have acute coronary syndrome. We have to differentiate it from pulmonary disorders like pneumonia, like asthma, COPD, which will have also clinical presentation of patients with dyspnea and problems of breathing. Transfusion-related acute lung injury, non-cardiogenic pulmonary edema, for example, presence of acute respiratory distress syndrome, which will lead to this. Pulmonary embolism, high altitude, wheezing also can be heard in both acute heart failure and obstructive lung disease like asthma exacerbation. Also, it can be also heard in COPD exacerbation. For the treatment of acute heart failure, we have to start with a rapid ABCDE approach to identify the cause of acute heart failure. The evidence of congestion, we have to check if we need a respiratory support. Diuretic therapy should be also done if there is a volume overload. We can give vasodilators like nitrates. We can give in hemodynamically unstable patients respiratory supports, inotropic supports like dobutamine and norepinephrine. If there is a shock with congestion, we give also respiratory supports. In shock without congestion, we do a fluid challenge. We add vasopressors and inotropes for shock refractory to fluids. If hypertensive emergency, we give non-invasive positive pressure ventilation and vasodilators for acute heart failure like nitroglycerin. Also, we give drugs for hypertension. Treatments of other triggers like atrial fibrillation, COPD, and pneumonia based on each like treatment approach for each disease. Beta blockers, we start them at low dose cautiously if the patient didn't have them before, only after stabilization. If the acute heart failure persists despite the treatment, we may use ultrafiltration like hemodialysis, mechanical circulatory supports, management of effusions using pericardiocentesis in case of pericardial effusion, and thoracentesis in case of pleural effusion as needed. For patients with diuretic naive patients, we give IV furosemide or bumetanide, and we assess the urine output every 6 hours. We may add as well thiazide diuretics in continuing the diuretic treatment. We may add also vasodilator for acute heart failure. We monitor the electrolytes level, like checking potassium to prevent the presence of ventricular arrhythmias. We have to check also renal function. If there is any contraindication to nitroglycerin, we give nesiritide, and we avoid the use of vasodilators in patients with hypotension and acute heart failure because they may precipitate hypotension. And that's all. I hope it was useful.